صباح الخير جميعا. احنا هنبتدي لان البرنامج بيقول نبتدي الساعة 9، ورغم ان لسه الاودينس قليلة. بالتالي كل اللي موجودين رؤساء جلسات وسبيكرز. احنا طبعا ده المؤتمر السنوي بتاع جمعية الضغط اللي ساهمنا في تأسيسها من سنوات طويلة مع الدكتور محسن المغي والدكتور عمر عواد وسليمان غريب وحسين رزق. حسين بقى انقطع عن يا ريت والله. هنبتدي الجلسة الأولى، وطبعا بنشكر كل المنظمين المؤتمر. والدكتور عمر بقى هيقدم الفيرست سبيكر. اتفضل.
صباح الخير، إن شاء الله يعني يكون مؤتمر موفق بإذن الله. وأنا بشكر زميلي العزيز دكتور محمد عبد الغني على الجهد الغير طبيعي اللي عمله عشان يخرج هذا المؤتمر في الصورة دي. وطبعا الصبح احنا بنحب ان يكون في برين ستورمينج، واحسن حاجه نبتدي بيها هي كيسز presenting by clinical dilemma هيقولها 3 of the outstanding young generation. اول بريزنتر هيكون الدكتور احمد محسن من كايرو يونيفرسيتي، وهيقدم لنا الحاله. وقولوا بس شير ويز احمد في possibility of diagnosis والinvestigations، يعني عايزينها تكون interactive قدر الامكان.
صباح الخير على حضراتكم. أنا طبعا بتشرف. Good morning, my dear professors and colleagues. It's my pleasure to be with you today, and I will talk about a very challenging scenario in management of hypertension, which is management of hypertension in patients with chronic kidney disease. Let's start with the case scenario. A 59-year-old man with chronic kidney disease was referred for management of high blood pressure. The lab studies showed that the serum creatinine level is 2.1 milligram per deciliter with estimated GFR of 33 milli per minute, and the albumin creatinine ratio was 500 milligram. And on examination, the blood pressure value was 160/90 millimeter mercury, and his current medications include amlodipine 10 milligram daily, hydrochlorothiazide 25 milligram daily. What is the most appropriate next step to control his blood pressure? Anyone want to participate?
Still, I think there is a compelling indication for drugs working on the renin-angiotensin system, and despite that his creatinine level is elevated, but it is not at the level which prevents us. In this condition, usually started, and we follow, and we see how much the creatinine will be. Another part, those patients with renal compromise usually have hypervolemia, and maybe loop diuretics will help in this condition. I think these two steps can be of value in the management.
Totally agree with you, dear Professor Omar. So we will proceed through our presentation to see the appropriate management of such cases. We will start with a rapid introduction. Chronic kidney disease is an increasingly prevalent condition globally and strongly associated with incident cardiovascular disease. Hypertension is both a cause and effect of chronic kidney disease and affects the vast majority of chronic kidney disease patients. Control of hypertension is important in those with CKD, as it leads to slowing of the disease progression as well as reduction of the cardiovascular risk. Let's start with the definition and the stages of chronic kidney disease. Chronic kidney disease is divided into 5 stages, starting with stage 1, which is defined as GFR 90 milli or more, but in presence of structural or functional renal abnormalities. Stage 2, GFR between 60 and 89, also in presence of structural or functional renal abnormalities. Stage 3 is subdivided into stage 3A and stage 3B. 3A, GFR between 45 and 59, and 3B between 30 and 44. Stage 4, GFR between 15 and 29. Stage 5, GFR less than 15 or dialysis. What is the definition of CKD in the guidelines for the management of hypertension? The American guidelines define CKD as stage 3 or higher, or stage 1 or 2, but with evidence of albuminuria more than 300 milligram per day. While the European guidelines define CKD as GFR below 60 with or without proteinuria. What about the guidelines for management of hypertension in CKD patients? Let's compare the American guidelines and the European guidelines. And starting with the blood pressure goal, the American guidelines recommend the blood pressure goal less than 130 over 80 millimeter mercury, while the European guidelines recommend systolic blood pressure between 130 and 139, and the diastolic blood pressure between 70 and 79. What are the recommended medications? In presence of proteinuria, such as our case, the American guidelines recommend ECI as a class 2A recommendation and ARBs as alternative and given only class 2B recommendation, while the European guidelines recommend RAS blocker as class 1 without preference for ECI over ARBs. In absence of proteinuria, the American guidelines recommend the usual first-line medication choices, including the ECI, ARBs, calcium channel blocker, and the diuretics, while the European guidelines recommend starting with combination therapy, RAS blocker plus calcium channel blocker and or thiazide. What about the use of MRA, mineralocorticoid receptor antagonist, in patients with chronic kidney disease, especially spironolactone, which is effective medication for management of refractory hypertension or resistant hypertension? The main problem is the side effects, especially hyperkalemia and the decline in kidney function, especially when added to a background therapy with ECI or ARB, and especially among patients with reduced GFR 45 milli per minute. So MRAs shouldn't be used in patients with high risk of hyperkalemia, including renal tubular acidosis type 4 or patients with hypoaldosteronism. And we can also consider the dose adjustment of spironolactone in CKD patients. In patients who develop hyperkalemia on a 25 milligram once daily, we can consider giving 25 milligram on every other day. And if the creatinine clearance above 50, we can start with 25 milligram once daily. Creatinine clearance between 30 and 50, consider initiating the dose at 25 milligram every other day with close monitoring of the serum potassium level, and it is better to avoid its use if the creatinine clearance below 30 due to relatively high risk of hyperkalemia. Important tips about use of ECI and ARBs in CKD patients. Before we start RAS blocker in CKD patients, we have to balance the risk versus the benefit. The risk or the barrier for prescription of RAS blocker in CKD patients include hyperkalemia, acute kidney injury, provider uncertainty or fear, and rapid decline in the kidney function. However, there are many benefits, including delay in the CKD progression, reduction in the MACE, major adverse cardiac events, and the mortality benefit. In patients with CKD who receive blood pressure lowering therapy, especially in those treated with ECI or ARB, blood pressure lowering reduces the renal perfusion pressure. And it is expected and not unusual for the GFR to be reduced by 10 to 20%, with rise in the serum creatinine less than 30% from the baseline. An increase in the serum creatinine level, if it occurs, will typically happen during the first 2 weeks of initiation, and it should stabilize within 2 to 4 weeks, provided that there is normal sodium and fluid intake. A change in the blood pressure, serum creatinine, and the serum potassium should be checked within 2 to 4 weeks of initiation or increase of the dose of RAS blocker, depending on the baseline blood pressure, GFR, and the serum potassium. But in the patients at high risk for hyperkalemia, such as high baseline serum creatinine or serum potassium level is already in the high normal range, or there is history of hyperkalemia or acute rise in the serum creatinine with the blood pressure lowering, measuring the serum potassium before and at 1 to 2 weeks after initiation of RAS inhibitor is recommended. Rise in serum creatinine more than 30% or reduction in the GFR by more than 30% from the baseline, the treatment should be stopped, and we have to rule out renal artery stenosis and check for hypovolemia and to rule out the use of nephrotoxic drugs. In most patients, ECI or ARB can be continued if the GFR decline over 4 months is less than 30% from the baseline and the serum potassium less than 5.5. Consider reducing the dose or discontinuation of ECI or ARB in the setting of either symptomatic hypotension or uncontrolled hyperkalemia despite the medical treatment. On the other hand, withholding these drugs only on basis of the level of the kidney function will unnecessarily deprive many patients from the cardiovascular benefits and perhaps even the protection of the residual kidney function that they otherwise would have received, particularly when measures could be undertaken to mitigate the risk of hyperkalemia. Consider the early causes of reduction in the GFR, which include hypovolemia, hypotension, renal artery stenosis, either bilateral or unilateral in presence of solitary kidney. And be aware of the absolute contraindication for use of ECI and ARBs, which include pregnancy, history of angioneuritic edema, bilateral renal artery stenosis, serum potassium more than 5.5, and the GFR decline more than 30% within 4 months without explanation. The roadmap to use the ECI or ARBs safely in patients with CKD include: you have to obtain baseline blood pressure, serum creatinine, GFR, serum potassium. Start with low dose with gradual up titration after at least 2 weeks interval until you achieve the target dose. Follow up the serum creatinine, GFR, serum potassium after 2 weeks or only after 1 week if there is increased risk of hyperkalemia. Avoid nephrotoxic drugs such as non-steroidal. Avoid hypovolemia and hypotension. Consider potassium binders such as patiromer. And also we can adjust the dose of RAS blocker in CKD patients such as ramipril. If the creatinine clearance is below 40, we can give 25% of the normal dose starting with 1 to 5 milligram daily, and the maximum dose is 5 milligram daily. And the valsartan, if the creatinine clearance is 30 or more, there is no need to adjust the dose. If the creatinine clearance is below 30, also no dose adjustment is necessary, but use it with caution. And in dialysis patients, the drug is not significantly removed through dialysis. Start with 80 milligram daily, and the target dose is 160 milligram daily. The last but not least is the diagnosis and the management of hypertension in patients with CKD maintained on dialysis. Let's start with the diagnosis. It is a little bit different from the standard method of diagnosis of hypertension. In those kind of patients, we depend on the average home blood pressure value. If the average blood pressure value more than or equal to 135/85 millimeter mercury for measurements collected in the morning, and in the evening over 6 non-dialysis days for 2 weeks. And the average value is 135. Over 85 or more, we can diagnose hypertension in dialysis patients. What about the recommended medications in hypertensive patients on dialysis? The first line is beta blocker, especially carvedilol and nebivolol. The second line is dihydropyridine, such as amlodipine and nifedipine. The third line will be ECI or ARBs, especially fosinopril and valsartan. Both are non-dialyzable, and the other antihypertensive medications came in the last position. So my final take-home messages: managing hypertension, especially when accompanied by chronic kidney disease, is challenging. Hypertension is the second leading cause of CKD, second only to diabetes. Although optimal blood pressure control is important for all patients with hypertension, in patients who have comorbid CKD, blood pressure control is crucial to slow down the progression of CKD. Early recognition of both kidney disease and hypertension may ultimately help to reduce the risk of cardiovascular events, advanced kidney disease, including end-stage renal disease necessitating dialysis or renal transplantation. Thank you so much.
Thank you, Ahmed, for this elegant talk. If I would start the discussion, first of all, you have explained very well that ACE and ARBs are not contraindicated in these patients. We are all usually, physicians are always afraid of giving these medications to patients with chronic kidney disease. Yes. Regarding calcium channel blockers, is there a preference of one over the other regarding the risk of proteinuria, to decrease the proteinuria?
Thank you so much, dear Professor Dr. Mohammed, for this very nice question. Actually, I asked this question for one of the brilliant nephrologists, as they deal with this kind of patients more frequently. And he told me that there is no preference for calcium channel blocker over another. And he usually uses amlodipine or Norvasc for these kind of patients with good results.
I just came across a paper stating that alteasem, decreases proteinuria more than amlodipine.
There is no consistency in the papers.
There are some new dihydropyridine calcium channel blockers that do reduce the creatinine. And they improve the proteinuria. Rather, they improve the creatinine and they reduce the proteinuria, but they have no evidence for cardiovascular outcomes, and that's the problem. These patients die mainly of a cardiovascular event, not of renal failure.
Yes, yes.
And that's what we should be focusing on, in my opinion. So I think get the blood pressure down. I wouldn't worry about the proteinuria. I would get the blood pressure down. And I would also treat them with a statin. And taking a more generic view of this patient, I think we don't have an idea what the patient was like, but maybe there were non-pharmacological things we could have done, because we're going to be pushing this person with more and more drugs. But if they're overweight, then we should be pushing on those other non-pharmacological issues as well, I think, just as a starting point.
Totally agree with you, dear professors.
If there is any question from the...
Thank you, Dr. Mohsen, for this elegant presentation. You know, this cohort of patients with CKD, extremely high risk sometimes for developing cardiovascular events, especially if they are hypertensive. If you will get to the target of the blood pressure, do you think there is still residual risk for such patients? Would you recommend for those patients other diagnostic modalities to improve precision of medications in such patients? For example, assessment of vascular stiffness, like pulse wave velocity or something else. What do you think about that?
Thank you, Professor Dr. Mohammed. Actually, the European guidelines for management of hypertension classify patients with chronic kidney disease as either high risk or very high risk according to the GFR. If the GFR is below 30, by default, they are very high risk patients. And in this kind of patients, we have to control all possible cardiovascular blood pressure or possible cardiovascular risk factors. Tight control of blood pressure, tight control of blood glucose if they are diabetic, strict control of the lipid profile, weight reduction, smoking cessation. You will try to reduce the very high risk in these patients by aggressive control of the cardiovascular risk factors.
Okay, thank you very much.
Thank you, sir. Thank you.